We shall now go on to our last speaker, Dr. Raghuraj Hegde, who is going to be bringing in the best in this very eventful webinar. Dr. Raghuraj is a consultant orbit ophthalmic plastic surgeon and ophthalmic oncology and services in the Department of Ophthalmology in Manipal Hospitals, Bangalore, and is also an adjunct faculty in the Department of Ophthalmology in Kempegowda Institute of Medical Sciences, Bangalore. On to you, Doctor.
Can you hear me?
Yes.
Yeah, thank you for the opportunity to the AOS ARC team. It's my privilege to be presenting today. I am to present my most difficult case. It's titled A Broken Eye, a Broken Face, and Lots of Tears. By the end of the presentation, I hope you will know why this title as such. The story starts in March 2019. I was called for an urgent consult for a road traffic accident where the patient was still in the ICU and while he was being intubated. I examined the eyes and I suspected there's something wrong with the eye. On examination, it was looking fine, and it was a self-filling corneal laceration was there from 12 o'clock to 5 o'clock. It was diagnosed via Stereolithographic positive, though it was self-filled. So it, also on CT scan, he had a Lifford 1 fracture, left orbital zygomatic fracture, a left orbital fracture, orbital floor fracture, inferior orbital rim, multiple fractures, which included the nasal bones as well. A mid-palatine fractures with migration of the upper alveolus superiorly, and the mandibular fractures as well. So immediately, because of the corneal laceration, and there was no cornea surgeon present at that time. So I wanted to operate on it and did a corneal laceration using the 10-0 nylon and 8-0 vicryl on an urgent basis. And basically at that point of time, I was present. And later on, when the patient was stabilized, patient was later taken up for primary reconstruction by the plastic surgery team. I was not involved in this particular surgery. After that, we had multiple orthopedic surgeries over the next few weeks. The patient spent a total of about 45 days in the ICU and another 6 months in rehabilitation to get back to his. The patient was lost to follow-up during the 6 months of rehabilitation. I had not seen him. He finally presented about about 6 months later, about in October 2019, with a chronic dacrocystitis. That was his main concern at that point of time. His left eye vision was 3/60, which is obviously due to the corneal scar post laceration repair. And he had a left eye inophthalmos as well as a restriction of eye movements superiorly. Other clinical findings was a loss of left malar prominence, a loss of bite on both sides. Only one tooth was able to make contact with the lower jaw, and a left zygomatic arch prominence also. On a CT scan, it confirmed all our clinical findings. We can see that the orbital rim of the left side is fractured, and the nasal bone as well as the zygoma is not properly reduced. And the maxillary sinus was obliterated on both sides, left more than the right, because the superior fixation of the upper alveolus. And the orbital floor fracture also was there.
मैडम कल कॉल कीजिए रात हो चुकी है
so there were a lot of moving parts in this patient, so a lot of issues also going on. So the easiest and the lowest hanging fruit was the chronic dacrocystitis, which was treated with endoscopic endovasal septoplasty, and dacrocystic rhinostomy was done at the same sitting. We did it immediately after that, and we intubated the ostium so that it would help us during the reconstruction later we planned. The next step was the secondary reconstruction of the face. So for that, we got a 3D printed stereolithographic models printed so that we could plan adequately and what were the things that we needed to do. At the same time, I also had to assemble a team to take care of the various issues with the reconstruction. So I teamed up with the maxillofacial surgeon who then suggested, seeing that the teeth alignment was wrong and it needed treatment as well. We also roped in a orthodontist by the treatment plan. So we did a virtual mock surgery using computer generated models and using computers to move the bones around and see at what so that we can get the optimum outcome. So we decided on a proper optimum outcome using mirroring from the other side, which is relatively better than the left side. The mirroring of the right side to the left, and we could arrive at some semblance of symmetry. We got it 3D printed, the new model that we were hoping to achieve, and we used this as a surgical guide for our orbital implant, so that so that it would be easier for us to place the implant during the surgery. So at the same time, we also had to take care of the teeth because he was not able to bite. So the orthodontic treatment, because there was a palatine fracture, we had to plan the fracture reduction in such a way that it would be easier for the orthodontic treatment also after surgery. So we did the surgery in March 2020 this year. About a year after his original injury. So we first had to remove all the plates that were put in by the earlier team, and we use a transconjunctival route to reach the orbital rim and the floor of the orbit. We used a pre-existing scar that was there for the frontozygomatic sutures, and then we removed the plates from there, and also we did a bioral incision from the oral side to remove all the plates that was permanent. After that, we did took a bone graft from the iliac crest, and we used it as a strut for to bridge the space between the orbits and the upper alveolus. So it acted as pillars for the to make the space between them. And after we did that, we reduced the zygoma to the proper place and fixed the orbital rim. Then we fixed the orbital floor fracture, and then we fixed all the other buttresses into from the oral side. The post-operatively, there was orthodontic treatment that improved the teeth alignment, and the treatment is still ongoing. And how we were supposed to. This is the final plan. And post-operative CT scans were done, and we see that the zygoma is properly fixed, as well as the floor is properly reconstructed, as well as the rim is also done well. And 3D reconstruction of the implants of the pre and post surgery shows that we've achieved a relatively good symmetry on both sides, as well as we've increased the distance between the orbits and the upper alveolus, and even further orthodontic treatment is the teeth alignment also should improve over time. This is the post-operative clinical outcome. This is about 3 months out from surgery. We see that his alignment is the inophthalmos is better. The zygoma is restored to the original place, and he doesn't have any restriction of movement at 3 months time. And this is a pre and post comparison where we can appreciate the reconstruction, the secondary reconstruction that we've done. He still has orthodontic treatment going on at present. So hopefully it should get much better in the next few months. He still has a nasal deformity, which we plan to take it up in a further sitting maybe next month. We decided not to tackle it at the secondary reconstruction because it was too many things were going on. And left eye also, we thought of rehabilitating using a rigid contact lens trial with a cornea specialist. The best corrected vision improved from 3/60 to 6/36. And even though he has a little bit of hazy vision because of the central scarring, but there was no diplopia in any of the gazes. We are planning a penetrating keratoplasty next month. So the timeline of surgery was when he March last year when he had the accident. In October when he presented with the dacrocystitis, it was treated with the DCR, and then the secondary reconstruction at March 2020, and July we did the visual rehabilitation with partial success. So next month we are planning to do a rhinoplasty with some scar revision as well as a corneal transplant. So in conclusion, the primary repair is the best answered reconstruction. So a holistic approach to addressing various issues is important. And a secondary facial fracture repair gives a lot of headaches. It's quite painful for the patient as well as the surgeon. So detailed planning is required because there are a lot of moving parts and the bone volume loss of malnutrited factors. So, and it also for best outcomes, we need a very multidisciplinary teamwork with all members of the team understanding their own limitations. And
1 minute.
so, I would like to acknowledge all the other surgeons who are involved in the care of this patient. So, thank you very much for the opportunity.
That was
Take any questions.
That was a terrific surgery which we all saw. Anything to be asked by the expert panel?
Excellent, excellent. And I think the one big take home message is multidisciplinary approach in this particular scenario. And I think that's been well carried out. Thank you so much, Dr. Raghuraj.
Thank you.
Yeah, that was a wonderful presentation. So I think we've come to the end of the webinar, and it calls for a very huge thanks to one and all of you. Every single person, this awe-inspiring faculty, the expert panel, you have made it such a remembered webinar. Special thanks to the admin team of AIOS led by Mr. Kripal. A thanks to Mr. Sunil, who was in webinar in charge. My very special thanks to Mr. Sai and Manjula, who have always been backup for us. A thanks to our sponsor, the Entod Pharma, who have backed every single venture of ARC. And of course, my very special thanks to my very endearing ARC team. And most importantly, I think we need to thank all attendees for their encouragement and participation, which is how each of these webinars continue to be a success. Thank you, one and all of you.
Thanks, thank you so much. It has been an excellent meeting. And I think lots of messages for all of us. Everybody's learned a lot from this. Thank you so much. Shruti, thanks to you. Dr. Satyajit, it's been very good. And all the panelists, really good. Everybody's been pitching in and with a lot of minds for all of us.
Yes,